growing, it tends to have that going out of the joint. Not to say there isn't that opportunity or that circumstance where you fall and you jam it, but more often than not, most upper extremity things, because of gravity, have a propensity to have that distraction. So the correction is primarily compression. You'll understand that particular context. So, Vinny. So with the glenohumeral joint, it has a propensity to have primarily aspects of an inferiority. It also has a propensity for an anteriority. Some of this, when you palpate, as we did last week, and check out or look at somebody's posture, it's always going to have that inferior thing because it's just hanging down, right? And if a person has that propensity for rolled shoulder forward, that's going to also have the propensity to make it go anterior. So the correction is you want to put your sternum on the corresponding scapula. So to accomplish that, you have to get down kind of in a fencer's position. I'm going to reach around. I like to cup my fingers like this so that I have the glenohumeral joint. Now, excuse me, the distal humerus, like the olecranon here. But you need to be kind of careful about when you get this set up. You don't want to kind of do it like you're pushing his head over like that, right? You want to kind of have enough clearance for that. So usually what I do is I bring this shoulder up and see if that causes any pain. If it does, I may need to modify what I'm going to do, but it gives me an opportunity to see how far the patient can come up. And then I'm going to bring him up, and then I'm going to let him down. If I bring him up like this and hold it there, Heath, and if I do this, then I know he's not relaxed. All right? So I can tell, yes, he's relaxed. You want to make sure also when you do this correction, he's not going to punch himself, or he's not going to punch you. Right? So the idea is, and you can see that I've got my fencer stance, shoulder or sternum on his scapula. I'm going to bring all this traction up. Sometimes I might do a little bit of pre-mobilization or a little vibration to make sure he's relaxed. But once I get him up there, it's just straight up to the ceiling. All right? So that's the glenohumeral for an inferiority. For an anteriority, I'm going to bring him up this way, and then I'm going to push towards myself. Same kind of thing. Sometimes I'll kind of see what the patient's tolerance is, and then just push in that way. Now, there are occasions, if there may be a slight variance in where I might have felt when I was doing this, it seems like right there's a click. Maybe that's the direction that I want to make that correction in. Or right here, there's a kind of a click. So by doing that, I can do what I call the windmill. But basically, it's the inferior correction and the anterior correction. So that's what I want you to retain were the two primary ones for the glenohumeral joint. The acromioclavicular joint, again, it's usually the acromion is not going to change its position really because it's anchored obviously to the scapula, and with that whole weight thing, it tends to stay here. So if you've had an AC issue, it's typically the distal clavicle that's going to be, malpositioned, or it's going to be superior typically. And so you can also, when you find that joint, you want to find that joint space, then I can also do joint play. Pressing down on the acromion, pressing down on the distal clavicle. The distal clavicle is going to move more, right? Because it's more free-form bone than the acromion is because of the context of it being connected to the scapula. So that's normal. You've got to take that into consideration when you're doing that. So it does seem like it moves or it doesn't move. Or this is not, again, a correction. Like I separated my shoulder yesterday. Could you do this move? It's probably not a good thing. But at some point in time down the road when things have settled, and result of the fibrosis and repair process, you still may have that superior clavicle. So, palmar surface of your index knuckle is going to go on the distal clavicle. All right? And then I'm going to kind of push down. So this is very much like Neer's test, but this is not really the test. This is a manipulation. As much as I can, I'm going to have my hand be perpendicular to it. I'm going to grab his distal humerus, because the humerus is what's going to contact the acromion, and by virtue of the fact that it's going to impinge it, it's locking out the acromion, so the acromion is not going anywhere. So it's locked out, slack down, and then just thrust straight down to the table. So again, as I mentioned in class, these thrusts are not like They don't look big, boom, like rotating somebody's head or doing this kind of thing. These are a little bit more discreet. So they can be done with a little bit, perhaps not necessarily less velocity, but perhaps in the big picture, more discrete kind of force. So again, this is why they're kind of easier, okay? So that's one way to correct the AC joint. The alternative way to do that is where you and the doctor, the patient is seated and you are seated. So I'll do it on this side here. So he's going to put his arm over my shoulder. Now sometimes when people have bum shoulders, you have to be kind of careful about how you get it up there. And then I'm going to palpate and I'm going to find that AC joint again, right? I'm going to put my middle finger, doesn't necessarily matter, but I think it's easier to use this hand because this is kind of closer to the distal clavicle, right? So it's going to come on it. My other finger is just going to cover it. Then I want to make sure that my forearms line up, kind of coming down that that distal clavicular line. So I'm not doing my correction like this. My correction is more around like that. And then this would be for a female, if you wanted to do this, they could put their hand on their shoulder, and so that my hand would be kind of like on contacting their hand rather than perhaps having a contact with the breast. And so I can bring his arm up, so that creates a little bit of that kind of like leverage. I'm going to pull down, and then once I get that slack out, I just go straight down like that with both my hands kind of together. All right? So that's the glenohumeral and acromioclavicular. So let's just practice those up, and then we'll come back and do the sternoclavicular, okay?